Thank you very much for your very kind words of introduction, and thank you very much for inviting me to speak. And I will be speaking today on the difference between SGLT2 inhibitors and diuretics. Um, the first thing that we need to know is loop diuretics are useful in heart failure in an acute setting, and there's no doubt about it. They have the benefit of legacy, but SGLT2 inhibitors increasingly seem to be more aligned to the heart failure pathophysiology. So this is this beautiful review article which was published in Cell Metabolism, and I would suggest that all of you read it at some stage because it really provides a deep insight into heart failure and the pathophysiology and how SGLT2 inhibitors might be useful and in fact even synergistic with the treatment with other drugs as well. So just to go through this in a little bit more of detail, SGLT2 inhibitors, as we know, work on the proximal tubule, whereas the loop diuretics work on the Henle's loop, and the thiazide-like diuretics like hydrochlorothiazide, chlorthalidone, indapamide work on the distal tubule, whereas mineralocorticoid receptor antagonists like eplerenone and spironolactone work on the collecting duct. They have certain very strong differences between themselves, with not only the site of the nephron where they act on, there is a difference between mild to strong effect that they have on the diuretic potency, with SGLT2 inhibitors, thiazide-like diuretics, and MRAs being completely mild and mainly being used for the treatment of hypertension, diabetes in SGLT2 inhibitors. But loop diuretics are kind of fixed for the treatment of congestive heart failure. MRAs have shown benefit in reduction of heart failure and refractory hypertension, but have the problem of tendency of causing hyperkalemia, whereas loop diuretics and thiazide-like diuretics cause hypokalemia. Uric acid is decreased by SGLT2 inhibitors, but increased by thiazide-like diuretics and loop diuretics. There is no effect of MRAs on the uric acid levels. Glucose tolerance is improved by SGLT2 inhibitors. We have robust data showing that SGLT2 inhibitors are a powerful glucose-lowering molecule. And thiazide-like diuretics, loop diuretics increase blood sugar. Lipid profile is deteriorated by thiazide-like diuretics, and hematocrit is increased by SGLT2 inhibitors and loop diuretics. So the effects of SGLT2 inhibitors, as you can see, is quite different from that of different classes of diuretics that we have in our system. But the focus of today is the heart failure and the kidney failure side of things, and we will focus mainly on the RAS. The RAS is basically the renin-angiotensin-aldosterone secretion system, and renin drives the secretion of angiotensin-1 from angiotensinogen, which gets converted into angiotensin 2 with ACE, and this leads to tubular sodium and chloride reabsorption and potassium excretion with water retention. This also leads to an increase in sympathetic activity. We also have angiotensin 2 working on the adrenal glands, increasing aldosterone secretion, which in turn again causes sodium and water retention. Angiotensin 2 is quite a bit of a villain. It works on the arteries, causing arterial vasoconstriction, increase in blood pressure, and also causing a negative effect on ADH secretion, which causes increased water retention. So all in all, these translate into increased sodium and water retention, effective circulating volume increases, which again goes back and works on the kidney, leading to further increase in renin secretion. So renin becomes a very important part of the pathophysiology of salt and water metabolism in patients with or without diabetes. And it is here that SGLT2 inhibitors seem to be having a bit of a positive effect in the sense that they work on extra volume contradiction and arterial pressure reduction by working on renin. And this goes through this entire cascade, as you can see, of angiotensin being converted to angiotensin 1 and then to angiotensin 2, and these working on the various receptors. And the translation of all this leads to potential cardioprotection by vasodilatation, sodium excretion, anti-proliferation, anti-hypertrophy, and anti-inflammation, whereas its effects on the MAS receptor also causes vasodilatation, sodium excretion. In addition to all these things, it causes cardiac remodeling and positive inotropic effect, which are all potentially cardioprotective. So this is the proposed mechanism of reduced CV death and heart failure in patients who use SGLT2 inhibitor by working on the renal system of the body. And in the kidney, in disease, there is increased glucose absorption with increased glomerular pressure and RAS activity, with decreased adenosine production and TGF. We have decreased sodium delivery at the macula densa and decreased ATP production. But with SGLT2 inhibitors, what we see is in the proximal tubule, there is reduced glucose and sodium absorption, which reduces the demand for ATP, OTP, and oxygen. And this increases sodium delivery in the macula densa, which improves the energy production. And all these translates into decreased glomerular pressure and decreased RAS activity, which I have shown you is beneficial in producing vasodilation, reduced sodium, and also cardiac modeling, remodeling, and improved cardiac function. So these are the cardiorenal protective mechanisms of SGLT2 inhibitors with natriuresis, reduction of blood pressure, modulation of translational growth factors with improvement of salt sensitivity and improvement of the sympathetic nerve hyperactivity. As we know in the EMPEREG trial, there was reduction of blood pressure with no increase in heart rate, which is a very strong proof of this effect. Metabolic factors probably are not so important, but there is a reduction of body weight and uric acid lowering, which might be improving. And also there is improvement of erythropoiesis, inhibition of NHE in the heart and kidney, and improvement of the cardiac metabolism by switching of the glucose to more energy efficient metabolites like ketone bodies, free fatty acids, and BCAA. Now, this is the positive effects of SGLT2 inhibitors on the heart and the kidney. What happens in the kidney with loop diuretics? Now, in the loop diuretics work on the effects on the macula densa with increase in 20-hydroxyethyl econoic acid, which is arachidonic acid mediator, and this leads to vasoconstriction. In fact, there is also an effect of furosemide on working on the pump of the sodium potassium ATPase pump. This works on nitric oxide synthetase and increases nitric oxide, which might also be reducing vasoconstriction. But the main effect is through the COX-2 dependent manner, which increases prostaglandin and increases renin secretion, which causes vasoconstriction in the afferent arteriole, increasing the pressure in the glomerulus. Now, all this translates into increased plasma renin activity. As you can see, this is bumetanide, a loop diuretic. When you first give bumetanide, you can see plasma renin activity going up tremendously, whereas if you give the patient dapagliflozin, there is no change in the renin activity. At this point of time, there is a crossover, and here dapagliflozin is given. You find that the plasma renin activity starts to come down, whereas you give the patient bumetanide out here, and you find that the plasma renin activity goes up. So SGLT2 inhibitors do not increase renin activity, whereas loop diuretics increase renin activity, thereby increasing the renin-angiotensin system's actions and leading to the deleterious effects that we have seen with loop diuretics. So this compensatory increase in sodium absorption mitigates the natriuretic effect. This is known as the braking phenomena or the resistance to diuretics. The SGLT2 inhibitors, on the other hand, do not inhibit the macula densa, and it doesn't provide a stimulus for the RAS activation. It can decrease some of the compensatory mechanisms for sodium reabsorption, leading to more sodium loss from the kidneys. There is also a sustained decrease in blood and plasma volume with empagliflozin that we have seen, consistent with the mitigation of the braking phenomenon, which I showed you a little while back. And all this translates into certain very significant clinical findings. As I said, loop diuretics are still important in the treatment of heart failure in an acute setting. But if you use loop diuretics chronically, there is an increased rate of mortality to the tune of 31%, which is statistically significant. And mortality due to heart failure is also significant to the tune of 36%, which is also strongly statistically significant. Hospitalization due to heart failure is also increased by usage of chronic loop diuretic therapy to the tune of 37%, which is highly statistically significant. So this is about loop diuretics. We have strong data about mineralocorticoid receptor antagonists be a very good drug for the treatment of heart failure. But what about mineralocorticoid receptor antagonists in heart failure and type 2 diabetes? Now, the data on this is restricted, and this is basically taking away a little bit of information, subgroup analysis of diabetic patients in the heart failure trials. And as you can see from this very robust meta-analysis, which was published in 2016, there is a definite positive effect on all-cause mortality by the usage of mineralocorticoid receptors in patients with diabetes and heart failure. There is a reduction in 4% extra reduction in heart failure in diabetics who use MRA. But this is compounded by an increase in potassium levels, and there is a marked risk of hyperkalemia in diabetic patients who use MRA when you compare it with patients who are non-diabetic. And therefore, the current recommendation is that there is still no strong evidence for the usage of mineralocorticoid receptor antagonists in diabetics, and more RCTs need to be done with larger sample size and longer term follow-up to come to a conclusion whether MRAs should be beneficial in type 2 diabetes. Thiazides in type 2 diabetes have no effect on cardiovascular death on major coronary events, but indeed what they do is they increase the number of major adverse cardiovascular events with an increased number of strokes, as was shown very robustly in this paper published in Hypertension. This was, of course, in patients with well-controlled hypertension, and I'll define you what is well-controlled hypertension, and you will know that comprises most of the patients that we see. So this is patients, the well-controlled and the not so well-controlled were defined between patients who had a blood pressure of less than 135 were considered to be well-controlled. Patients who had a pressure of 145 were considered to be less well-controlled. So you see, most of our patients who have hypertension and are on drugs would have a blood pressure around 135 systolic, and they would fall into this large category that's been trialed and published in Hypertension in 2019, showing that thiazides would be risky in type 2 diabetes patients. Contrast to this, we find some beautiful data. This is the first lot of studies that we meta-analyzed, and we find that there is a reduction in CV death or hospitalization for heart failure, and a reduction in hospitalization for heart failure, which is statistically highly significant, with very low heterogeneity that you see in these trials. And you find there is a very strong improvement with the diamonds sitting very robustly to the left of the unity, showing that there is a strong benefit in heart failure and CV death or hospitalization for heart failure in patients who use empagliflozin, canagliflozin, or dapagliflozin. This has, of course, been replicated recently in non-diabetics with a strong suggestion of reduction of cardiovascular death, hospitalization for heart failure or urgent heart failure. This is the DAPA heart failure study. There was a reduction in cardiovascular death. There was a reduction of cardiovascular death or hospitalization from heart failure, as well as death from any cause. And this has been shown to be proven to be correct again, with the primary outcome of CV death or hospitalization for heart failure being achieved by empagliflozin in patients with or without diabetes in a reduced ejection fraction, a strong signal of its efficacy in heart failure, coming out very clearly from very early on in the disease in patients with heart failure with empagliflozin. Again, a meta-analysis of these two trials have shown very convincingly, this is published just a week ago in the Lancet, that there is a strong reduction of mortality, strong reduction of cardiovascular death, heart failure, and kidney outcomes, which are beneficial in patients who are on empagliflozin or dapagliflozin with or without heart failure, proving that these are very strong anti-heart failure drugs. In addition, we have the DAPA-CKD data, which again is suggesting a reduction of a composite of reduction of renal function, renal disease, and renal or CV death, and also translating into secondary outcomes of reduction of CV death or hospitalization for heart failure and all-cause mortality. Now, SGLT2 inhibitors and classic diuretics, of course, I've described all this to you, but I will summarize again that the main reason why there is a difference is because of this effect on the RAS activation. Classic diuretics increase RAS activation and increase sympathetic activity, and therefore lead to worsened cardiac outcomes, whereas SGLT2 inhibitors do quite the opposite, and in spite of causing natriuresis and reducing interstitial fluid loss and total volume, they do not cause any kind of the effects that we see with classic diuretics. Now, that is why today we have the situation that foundational therapy in heart failure is being moved quite a bit. In addition to the ARNIs, ACE inhibitors, ARBs, MRAs, and beta blockers, we now have SGLT2 inhibitors. In the story of SGLT2 inhibitors goes from diabetes to non-diabetes, from normal ventricular function to end-stage heart failure, for heart failure prevention and heart failure treatment. And this is completely different to the data we have from diuretics, the traditional diuretics, and therefore it can be used in all stages of heart failure, whether the patient has diabetes or non-diabetes, even in the preclinical stage, at a clinical stage, and detectable cardiac involvement would benefit from usage of SGLT2 inhibitor, as evidenced by the presence of so many of these trials. But as my last speaker said, the holy grail still remains preserved ejection fraction. And we look forward to having some data which would be positive in those patients. But till then, SGLT2 inhibitors are winners, and they have taken the treatment of heart failure to a completely different paradigm. Thank you very much for your kind patience and letting me speak. Thank you so much.